Hello everyone. Today we'll see about papillary thyroid carcinoma. So this carcinoma has got excellent prognosis. It shows lymphatic invasion. Hence you will see metastasis in the regional lymph nodes, and it is more common in 3rd to 5th decade of life. And also females are more prone to papillary thyroid carcinoma are most commonly seen in female compared to male, almost 2 times more common in female than male. So coming to the etiologies, exposure to radiation, hormonal or some autoimmune causes. Apart from that, most commonly genetic factors. Genetic factors, you can see this tumor in familial adenomatous polyposis or Pearce-Jaeger syndrome or Cowden syndrome. So what is the most common mutation here? It is rearrangement of RET gene. So that is known as RET PTC gene. So in this, the fifth there is a fusion of tyrosine kinase domain of RET to fifth portion of various other genes. Apart from that, you can see BRAF mutation, also RAS mutation. Coming to the gross features, this tumor will be about average size of 2 to 3 centimeters, and they are white and firm in consistency. They show invasion, so there is capsular breach, and you can see occasional calcification, and also most commonly they present with cystic change or cyst formation is seen grossly. Coming to microscopy, you will see tumor papillae, okay, and this papillae will have core of fibrovascular core, and these papillae are lined by crowded cell nuclei, and also in the tip you can see samoma bodies, okay, which is nothing but dystrophic calcification, and the nucleus is clear, large, giving appearance of orphan Annie nuclei, and there can be intranuclear inclusion. Also you can see intranuclear groove or nuclear groove you can see. So there is fibrovascular core with the papillae with the fibrovascular core. There are crowded nuclei lining these papillae. There are samoma bodies. There is intranuclear inclusion, nuclear grooves, and clear large nucleus, which is compared to orphan Annie. Here you can see a papillae with a fibrovascular core, and here you can see the clearing. Also you can see nuclear grooving. This is samoma bodies. Clear nuclei compared to orphan Annie. Coming to IHC, thyroglobulin, TTF1. Apart from this, sometimes in some cases HPME1, galactin 3 and CK19. Remember, none of these are specific markers. Coming to poor prognostic factor, one is elderly age group. If it occurs in more male, it carries poor prognosis. The larger the size of tumor, poor prognosis. Extrathyroidal growth also shows poor prognosis. Also, it is seen that BRAF mutated genes tumors have got aggressive features. Coming to variants of papillary thyroid carcinoma. First is papillary microcarcinoma, wherein tumor is 1 centimeter or less. Next, coming to follicular variant of papillary thyroid carcinoma. This tumor appears encapsulated, but the cells have nuclear features of papillary thyroid carcinoma, which include clearing of nuclei, samoma bodies. In this, there are two types. One is diffuse follicular variant PTC, encapsulated follicular variant PTC. Next, coming to tall cell variant. Here the cells with 3 times as tall as the width. The length is 3 times the width. And the cytoplasm is eosinophilic, which is also termed as pink cell. And this should be about 50% of all the cells in the tumor to call it as tall cell variant. Here you can see the pink cells. Coming to columnar cell variant, here you can see papillae which is lined by tall columnar cell which has got scant cytoplasm, and also you can see frequent mitosis in here. Coming to Warthin-like variant, this tumor usually arises in background of chronic lymphocytic thyroiditis. So you see papillae, tumor cells with abundant eosinophilic cytoplasm, and this papillary core contain lymphoplasmocytic infiltrate. Coming to Papillary Thyroid Carcinoma with Nodular Fasciitis like stroma, it is a rare variant wherein tumor cell shows cords, tubules, papillae, nuclear features of papillary thyroid carcinoma with varying degree of squamous metaplasia and are embedded in unique fasciitis like stroma. Coming to cribriform morular variant, which is commonly associated with familial adenomatous polyposis syndrome, which is a multifocal tumor with cribriform solid or spindle cell growth pattern with nuclear features of papillary thyroid carcinoma. Coming to other two patterns, diffuse sclerosing variant. This diffuse sclerosing variant is most commonly seen in children in Chernobyl incident, and there is squamous metaplasia, there are numerous samoma bodies and lymphocytic infiltrate around these tumor foci. Similarly, solid cell variant is also seen in children and these are widely invasive. This is diffuse sclerosing variant of solid tumor nest with numerous samoma bodies, and you can see lymphocytic infiltrate around the tumor foci. This is the solid arrangement of the tumor. Then coming to Hobnail variant, the tumor cell nuclei located in the middle in the apex of the cytoplasm that gives rise to bulging of the nuclei at the tip of the cell, which imparting the appearance of the hobnail, hence termed as Hobnail variant. In this, the nuclei is in the tip giving a bulging appearance, giving appearance of a hobnail. There are various other patterns which include Hertel cell variant, PTC with lipomatous stroma, encapsulated variant and myxoid variant.